content discussed on this program is often medical in nature and is used for informational purposes only. No content discussed should be taken as medical advice. Please consult your healthcare professional for any medical questions. Hi, I'm Tori McGee, and this is the Rapid Recovery Report sponsored by ROMTech, the modern technology of rehabilitation. We'll be doing this series 4 p.m. Pacific, 7 p.m. Eastern Thursdays, where we talk to different guests. Sometimes it's surgeons, sometimes patients, sometimes insiders here at ROMTech. And we talk about all things wellness, health, and we will actually touch on ROMTech's Portable Connect. Now, if you are new to ROMTech or the Portable Connect, you can see this little cutie right here is exactly what we've been talking about, our Portable Connect. So it is a high-tech recovery device, and it's basically just geared to get people moving and recovering from surgeries faster and just get back on their feet. So if you want to learn a little bit more about it, you can always visit us at www.romtech.com. And also please subscribe to our channels and just check us out. We'd love to hang out with you.
It's hard to describe success in just a few words. It means so many different things to so many different people, but in the world of orthopedics, there is a doctor who is the quintessential definition of success and also an example of how to build your practice, innovating along the way for 35 years and still going strong. Dr. Samuel Gerber is that definition of success. Dr. Gerber has set the excellence bar very high 35 years ago, and guess what? It's even higher now, if that's even possible. Dr. Samuel Gerber, we salute you.
So we've got a great guest today. Dr. Gerber is a graduate of Yale University and Harvard Medical School, and he's among the first in the nation to be awarded subspecialty certification in orthopedic sports medicine. He founded the Orthopedic Surgical Associates of Lowell and is a past president of Massachusetts Orthopedic Association and prior chief of orthopedic surgery at Lowell General Hospital. Dr. Gerber is also an adjunct professor at the University of Massachusetts Lowell, and he serves on the board of counselors for the American Academy of Orthopedic Surgery. And that's just a few of the awesome things that you're doing. Welcome, Dr. Gerber. We're so happy to have you.
My pleasure, Tori. Nice to see you again.
Yeah, you too. You're very impressive. That resume, my goodness. And I didn't even hit everything. So now when you started your career, what was the normal practice for pain management then? And was it, different for sports medicine versus a more general patient population?
Yeah, things have changed a lot over time, as you know. When we first started doing orthopedic surgery, people were in the hospital a lot longer. Mm-hmm. There was a lot more IV pain medicine, more narcotics being used, and less mobilization of patients. And the things that really have changed is we've gone to a more ambulatory model where people get up and around, they're moving quicker, and less narcotics. There's less addiction as a result. There's less chance for blood clots, and people seem to do better in terms of rehabilitation, getting up and around and being more familiar environment as well.
Yeah, I bet. Now, as medicine has had to rethink pain management after, opioid addiction and all of those issues occurred, can you tell me how well other methods have been working so far, in particular, like the multimodal approach, and what exactly is that for those watching and don't know?
Sure. We went through a transition where people were getting injectables and by mouth medicines for pain, largely narcotics. And then they went to a PCA model in which people were administering their own pain medicine with narcotics as a pump. Then we went to long-lasting narcotics with the idea that we didn't want people to have any pain at all. And that all that led to was addiction. It really helped with the pain control.
Right.
And now what we've done between increased mobilization and using mechanical methods, using things like anti-inflammatory drugs in conjunction with Tylenol, nerve medicines that suppress nerve pain, and a small amount of narcotics in the beginning, people rehabilitate much quicker, better, have less complications from the surgery, and have less pain. Actually, motion itself will help people have less pain. And that's really, as we stress things, that you have to educate patients, though, is very important. a lot of them will say, well, I can't move it because it hurts. I said, no, if you don't move it, it's going to hurt. So you need to start moving it, and it'll pump some of the fluid out of the tissues and make them more pliable and make more flexible, and you'll be able to get moving.
Yeah. I mean, I know growing up, I used to tell my mom, it hurts when I do this. And she'd say, well, don't do that then. And so most of us are kind of conditioned.
I think we all have the same
that.
mother.
Yeah. We're all conditioned to that. So, it hurting to do that makes us not want to do that. But
Right.
Of course, movement, body in motion stays in motion. Movement helps.
Absolutely.
So you had said something interesting in an earlier conversation that we had that was, patients used to spend like 10 days in the hospital, for knee replacements as part of the normal procedure. And now we have surgery day centers. So do you believe that all procedures could be migrated to like a surgery day center presently?
Probably not all. I mean, it really depends a lot on the patient's other comorbidities, their other medical conditions, their age, their family support situation, what the psychosocial situation is for the patient. I mean, if they just have people at home, do they have a lot of stairs at home? How well are they moving ahead of time? What other medical conditions do they have? How functioning they are mentally. Some people just can't process all the information, particularly elderly people. They need a lot of cues. And so sometimes a day or two in the hospital is necessary. But I would say probably it's going to be the majority of people, at least with total knees, that will be able to do as day surgery at some point in time.
Yeah. My grandma just had to have a plate put in because she had fractured a bone in her leg and she could not wait to get out of the hospital. But she's a very busybody and bossy lady. So I'm sure all of those folks with that same kind of personality are very excited that it's now a quick in and out, outpatient procedure.
For a lot of people, they feel much more comfortable in their home environment anyway. If they have a good support system, it's just a better place to be. Plus, you're not around other people who can bring you infections of all sorts.
Right.
These days, we worry about that, obviously. And if you're home, you're going to be more mobile. You're less likely to get blood clots and other complications from the surgery.
Yeah, that makes sense. Now, I wanted to ask you about proper prepping before a procedure. And you really, stress this practice beforehand. So can you explain what prepping is?
Well, we think of prepping as just prepping the skin, but no, it's prepping the patient for being able to have a major procedure. They have to be educated, first of all. They have to understand what's going to happen to me. What can I expect? How is this going to affect my life? When will I be on crutches? When will I be using a cane? How quickly will I be moving? When I'll be able to take care of my dogs and take them for a walk? All those sorts of things. So a lot of it's education. I like to have patients see a physical therapist ahead of time, and hopefully the same therapist they're going to see later on, so they understand what they're going to have to do, get on to the various devices they're going to use, the modalities they're going to use, so they understand, and also walk up and down stairs ahead of time and figure out how they're going to do that with a cane or a crutch, and how they're going to manage at home. So that's always very useful. And I have a wonderful physician assistant who works with me, who really helps with that education as well, sees the patient a week before and spends time with them, kind of going through all the things they're going to get. When you need to call for your pain medicine, when you need to get off your pain medicine, when you need to start moving and starting therapy, and in terms of the ROMTech and the Portable Connect, when you're going to get that, when you're going to start on that, and how you're going to manage that. So those are all important things. Then it doesn't become overwhelming when you have a procedure. I mean, having a major surgery is still a major surgery. And if you're prepared, you're much more likely to be successful and have a good result. If you're not prepared, it all comes as a big stress to people. You don't need to add stress on top of surgery.
Yeah, no kidding. So the process for prepping, it's going to be a little bit different depending on patient's age, right?
Beyond patient's age, sometimes language issues are, we have communication issues with people. Sure. And sometimes people bring a whole psychological overlay that's different for everybody. Some people are used to dealing with stress and managing a stressful situation. Other people need a little more emotional support. And so you get to know that as you get to know the patient. It's important to understand the patient and know them. And by understanding that, you can get them through it and make them have a successful result.
Okay. That's great. I love that you spend so much time to kind of learn about each individual patient and what would be best suited for them. Even, something as simple as explaining to them the process of before and after, a surgeon that cares.
Well, you have to listen to the patient. That's the only way you can know what they're thinking and talk to them. And you got to
Absolutely.
spend a little more time listening than talking. That's
Yeah.
we all have things we want to say, and we kind of feel pressured to get them in a short period of time. Sometimes you learn a lot more by just being quiet and just listening, let the other person talk.
I think so too. So tell us a little bit more about, some of the non-opioid pain management techniques that you're using, like, iovera.
Right.
I know you had mentioned that one before.
Yeah, for sure. iovera has been a great benefit for the people that the insurance will allow it. And my PA does this. It's a way of freezing the sensory nerves ahead of time so that there's less pain after the surgery. And obviously, they have less pain. It's easier for them to move, and they require less medicines.
How long does, the freezing essentially last?
I think it lasts a few weeks.
Oh, okay, great. Well, that's awesome.
Yeah.
Now, do you ever worry about patients overdoing it because the, iovera has frozen?
No, I really don't, because it doesn't relieve all the pain. It just gets rid of the sensory pain that you have. You still have the feeling of what's called proprioception, of feeling where your joint is in space. When you're walking to a dark room, you can feel where your feet are when you're walking. You don't have to see your feet in order to know where they are. That's a proprioception. That's not dead. You still have that available to you. So you have a good sense of where your body is. You just don't have as much pain in moving.
Okay. Not like Novocaine, huh?
No, it's not like being completely numbed. That's correct.
So, okay, I want to ask you about the results that you discovered when you started using the ROMTech Portable Connect with your patients. So you found
we've had great results with that, Tori. I'm sorry, I didn't mean to interrupt you. We've had great results. We actually had one patient who we had a little video from ROMTech about, who I had done the first knee without ROMTech and the second knee with ROMTech, and she said it was like two different experiences. Her second experience, which had very little pain, she was moving. She was 3 months ahead of where she was with the other knee at one point. So she was really delighted with how that worked out. And I've had that experience largely. Most people have come back and have done very well with their motion, and they feel like they're participatory in their rehab. It's not somebody's doing something to me, but rather I'm part of the whole process. I'm using this device. The device interacts with me. Some of it's passive, some of it's active. It's interactional, and the therapist can get data off of it. Also, that's very useful.
Yeah, I mean, that's a pretty dramatic comparison. 3 months ahead of where she was with her first knee.
Yeah,
it's huge.
Yeah, she was delighted.
Yeah, I bet I would be too. It's interesting, the willingness I think that patients have to do more with their recovery when they have a portable Connect device versus just doing exercises that a physical therapist had asked them to do. I don't know if it's, the feeling of having something high tech in their home and them really wanting to go for it, or them being able to actually see in a chart their progress, but something's motivating them a little bit more than when the, physical therapist says, okay, do this 3 times a day when you're at home, these exercises.
Well, nothing is more motivating than having results that you can see you're progressing. So when you can see I'm improving, it gives you more incentive to work harder to improve even more. And that's true. I mean, you see that all the time. People in their study habits, people who are good students, they get positive reinforcement for being good students. They study harder. People who are told, oh, no, you're doing terribly. And then they kind of give up on it. Say, well, I'm not good at math, or I'm not good at this or whatever. And they just stop trying. And a lot of times it's just getting their confidence back and making them feel like they're part of the process and that they're making progress. And I think the ROMTech Portable Connect has been really good in terms of that. It gives people instant feedback, and they can see how they're doing better than they did last time. And they feel like they're part of the whole process. And that's just how people react and respond. We all like positive reinforcement. It makes us feel good. Nothing makes you feel better when somebody give you a compliment, make you feel good about how you're doing in your day. And and then that's part of the nice thing about seeing patients, that they come back and they tell me, I feel so much better with my surgery. It's it's like a positive reinforcement for me too, to be doing what I'm doing.
Yeah, absolutely. I mean, that's why surgeons stay up on what's modern, because things are just
Absolutely.
getting a little bit better.
Absolutely.
So you had mentioned that you're enjoying, overall maturing of your practice. You said that it matured along with you.
Well,
So,
it's
a
true.
move to more total knee procedures. So,
Well, part of that is, we talked. I had done a fellowship in sports medicine and arthroscopy, and a lot of patients who 20, 30 years later end up with arthritis, they need to still be taken care of. So I've always done knee replacements, but the percentage of my knee replacement practice probably has increased a little bit as my patients have aged along with me. So that's because that's what they need.
yeah,
And you don't do things because you want to do them. You do them because that's what your patients need. And so my patients have progressed along with me, and so has my practice. And it is kind of funny how everything develops and matures in a certain manner.
Yeah. Well, I mean, here's the thing: if you did, like an ACL procedure on me before and did such a great job, and then eventually I need that knee replaced, who am I going to go back to? Right.
Well, it's very comforting to see people do that and come back to see me. It's
I
nice.
bet.
I also have multi-generational families that are coming to me as well.
Oh, that's great. I love that. We have that in like a primary care physician. My grandma goes to the same guy my mom goes to that I go to. Find somebody you like.
Absolutely.
So in your overall medical experience, do you feel that there's still room for improvement for overall patient care?
Of course. That's what, I mean, that is what the practice of medicine is. That's why we call it the practice of medicine. We're always learning new things and new ways to help people. And that's what's fun about it. That really is. I mean, every so often it's funny, you'll pull something out of your bag that is an old technique that works for certain rare situations. And I've added something that came up recently like that. And it's always interesting to you have all these new things. Then you say, well, sometimes something old might be worthwhile. Well, for this particular patient, we might pull this one out and try that.
That's fair. So now if you sat down with a young surgeon, what would be your first piece of advice to him or her as they venture into the world of orthopedics?
Listen to the patient.
Yeah. Yeah. Okay. Go back and rewind and listen to that again, you guys. Listen to the patient. Now, do you have any advice for someone who is seeking information about a knee replacement?
Well, there's lots of places that can look and get information. The American Academy of Orthopedic Surgery has an excellent website and has a lot of good references and videos and brochures and that sort of thing. I think that's an excellent reference for patients to go to and a good starting point.
Yeah. Is there anything that they should avoid as far as like misinformation or things to be careful of?
You be careful on the internet. I mean, the internet is it's like the Wild West in a sense. It's not regulated, and there's some excellent things on the internet, and then there's some total bunk. I mean, you're going to see some crazy stuff that people put on the internet as though it's the gospel, and it's just crazy. But so it requires a discerning eye, and a lot of times just go back and talk to your doctor about it. I had somebody today who was asking me about a new technique that's being done for anterior cruciate ligament reconstructions. And I said, yeah, that's what you read on the internet is a really good thing, but it's experimental and is not yet well accepted. And for the various reasons, I said, you're not a candidate for that at this time. So you wouldn't be appropriate for that. But it was an excellent question, and it was good information that she had. It just wasn't appropriate for her at that time. But it's hard to put things in context. So a lot of times just going back to your own surgeon and talking to them, I think they'll be able to put things in context and make them make sense for you individually. Again, a lot of this is individualized. You can't cookie cutter people. They're not meant to be cookie cuttered.
Yeah, well, that's fair. I mean, I imagine it's interesting to see what people come up with that they have found on the internet with their, Google Medical University degree.
It's all okay. I mean, it's just information that's out there, and it's good to talk about it. It's bad to be defensive or afraid to discuss things with patients. They have a question, they ought to answer it.
Yeah, absolutely. Absolutely. Well, yeah. I'm gonna come to you if I need a knee replacement.
That's a long way from California, Tori.
That's okay. I'm willing to travel for a good surgeon.
Bi-coastal, huh?
So do you think that there will ever be a future where all knee and ortho procedures will be done in a non-hospital setting? So like
I think the majority may be, and I think hospitals are redefining their roles right now. I think it's not clear. I mean, clearly the emergency room is a necessary part of a hospital, and intensive care units a necessary part of the hospital, and there's a certain number of hospital beds that are needed for medical care. Multiple trauma probably needs a hospital, but there's a lot of things we used to do in the hospital that have evolved over time. And it's not just in orthopedics. I mean, general surgery, hernias are done as a day surgery procedure. That didn't used to be the case. People were in the hospital 5 to 7 days after a hernia. So it's not just orthopedics. I mean, medicine has evolved and changed. And it's not just cost consideration. It's just health for the patient. It's the right thing to do.
Right.
And patients don't want to be in the hospital if they don't have to.
Right. I mean, I'd much rather be in a surgery center versus a hospital. So that makes sense. Well, thank you so much. I don't want to take up too much of your time, Dr. Gerber. This has been awesome. I have loved every minute of doing this interview with you.
Very sweet. Thank you, Tori.
It's been a lot of fun. Folks, if you want to visit Dr. Gerber and talk to him and you need to have a procedure done and talk to somebody who's caring and very informed, please visit him. His website and Twitter and email are all below. They're going to be in the description below as well. And, if you can't find it, you can always reach out to us at ROMTech.com. Ask us any questions that you've got and follow us for more information and videos like this. Finally, if you'd like to be a guest on our show, please email marketing@romtech.com and we'd be happy to chat with you a little bit. So thanks again, Dr. Gerber. I've had a blast with you and I hope that you had as much fun as I did.
I did. Thank you very much. It's been a pleasure talking to you today.
Absolutely. Bye-bye.
Bye now.